Welcome to The Explainer. Today we're diving straight into a huge topic, the absolutely undeniable two-way connection between our physical and mental health care.
Think about it like this. You take your toddler to the hospital for a broken arm, right? You head to one building. But if you're experiencing a severe panic attack, you're sent to a totally different building. You're treated by a completely different team of doctors who, well, they might never even speak to each other. Treating the mind and body in these isolated silos just completely ignores the reality of human biology. So let's really dive into this.
The core conflict we're looking at today is honestly a pretty massive paradox in modern medicine. See, when we treat just one half of a patient, we actually often end up inadvertently traumatizing the other half. It's wild. Aggressive physical treatments can cause really severe mental harm, and on the flip side, life-saving mental health treatments can take a devastating physical toll on the body.
So here's our roadmap for this explainer. First, the mind-body medical loop. Then we'll look at when hospitals hurt minds, followed by mental meds and their physical tolls. After that, we'll cover the collaborative care solution, and finally, the proof that integrated care actually works.
All right, Section 1, the mind-body medical loop and the cycle of fragmented care.
Moving right into Section 2, when hospitals hurt minds and how physical healing can disrupt pediatric development. To really grasp this loop, we need to look at our most vulnerable patients, kids. If we map out early childhood psychosocial development based on Erik Erikson's established theories, you see a very specific timeline. From birth to 1 year, a baby is basically just learning trust versus mistrust. From 1 to 3, toddlers are developing autonomy versus shame. And then from 3 to 6, preschoolers are figuring out initiative versus guilt. These are absolutely crucial formative years where a child's entire personality and coping mechanisms are built from the ground up.
But man, think about what happens when a kid is thrust into a hospital for a chronic illness. The necessary, life-saving medical stuff directly clashes with those exact developmental milestones we just talked about. If an infant needs a feeding tube, they lose that crucial oral stimulation that gives them comfort. If a toddler is separated from their parents for scans, it completely blocks their ability to build foundational trust. And being stuck in a hospital bed? That restricted mobility literally strips a toddler of their developing autonomy, which, you guessed it, often triggers aggressive behavior. We're essentially trading physical recovery for psychological rebellion, mostly because these stressors hit them way before they have the cognitive tools to cope.
This idea really hits the nail on the head, and it's rooted in Jean Piaget's concept of concrete thought. Young patients simply do not have the cognitive ability to view gross-tasting medicine or a painful needle as a cure. No way! Instead, their immature reasoning perceives these interventions as a direct punishment for something they did wrong. So while their physical body is being healed, their mental health is taking a massive, trauma-inducing hit.
Section 3. Mental meds, physical tolls. The metabolic cost of psychiatric care.
Okay, let's flip the coin. Because if physical care can break the mind, mental care can absolutely break the body. When adults are dealing with severe mental illnesses like schizophrenia or treatment-resistant depression, they're often prescribed second-generation antipsychotics, or SGAs. And look, these are incredible, life-saving drugs, but they come with a very serious physical warning label, metabolic syndrome. We're talking about a cluster of conditions here: severe weight gain, altered lipid levels, high blood pressure, and insulin resistance. Get this, between 42% and 62% of patients on these drugs experience severe antipsychotic-induced weight gain. That is huge.
So the key here is knowing which medications pose the highest risk. Drugs in the higher risk category, like olanzapine and clozapine, carry a significantly higher threat of metabolic disruption. To put that into perspective, prolonged use of olanzapine, say over 48 weeks, averages a weight gain of 5.6 kilograms. That's over 12 pounds, and it's directly triggered by how the drug messes with energy metabolism, delays feelings of fullness, and interacts with serotonin and histamine receptors in the brain. The end result of isolating mental from physical health care? It's genuinely staggering. Patients with severe mental illness face a lifespan reduced by 10 to 20 years. 10 to 20 years. They also have a 3-fold higher risk of obesity and a 2-fold increased risk of type 2 diabetes. In fact, the leading cause of mortality in schizophrenia isn't the psychiatric condition itself, it's cardiovascular disease. And that is heavily driven by the very medications used to keep their mental health stable. You can imagine the terrible dilemma this puts doctors in, right? Do you switch the medication and risk a devastating psychiatric relapse, or do you keep them on the drug and just watch their physical health deteriorate? Often, doctors are forced to resort to off-label treatments. They'll prescribe drugs like metformin or topiramate simply to offset the physical side effects of the psychiatric meds. It's just a constant, fragmented juggling act.
All right. Section 4, the collaborative care solution and bridging the gap with COCM. But listen, there's a way to break this cycle. It's called the collaborative care model, or COCM, and it's a structured approach designed to finally end this dangerous mind-body loop. Instead of sending a patient to a totally different building for mental health issues, organizations are using frameworks like the MICSI model to embed behavioral health care managers directly into primary care offices. Mental and physical health treated in the exact same room. What a concept, right?
And it all starts with visibility. In a COCM framework, primary care visits use routine standardized screening tools, like the PHQ-9 for depression and the GAD-7 for anxiety. If a patient comes in for a twisted ankle but scores high on anxiety, the primary care doc doesn't just hand them a referral slip and cross their fingers they find a therapist in 6 months. No, they take immediate action.
Let's walk through how this seamless workflow actually plays out. Step 1. The routine medical visit identifies a behavioral need. Step 2. An embedded behavioral health care manager steps right into the room to give immediate support. Boom, right there. Step 3. A psychiatrist is working behind the scenes reviewing the case and consulting with the primary care doctor on medication. And Step 4. The team makes proactive shared treatment adjustments. Finally, physical and mental health are managed simultaneously by one unified team.
Section 5, Proof Integrated Care Works. Better outcomes and lower costs. Now, this isn't just some nice theory. We actually have the hard data to back it up. Let's talk numbers. When clinics implemented an Evolved MD collaborative care program, they saw a massive 15.3% reduction in the total cost of care for Medicare patients. Why? Well, when you manage mental health proactively right there in primary care, you prevent those wildly expensive medical emergencies that happen when mental illnesses go untreated and end up making physical chronic conditions so much worse.
It also completely solves the resource bottleneck. Think about it. Because the psychiatrist in a COCM model acts as a background consultant for the primary care team, rather than seeing every single patient face-to-face for an hour, a single psychiatrist can reach up to 8 times more patients than they could in a traditional siloed setup. 8 times!
But honestly, the most vital metric here is how fast patients actually heal. A retrospective study at Mayo Clinic found that patients in usual fragmented care took an average of 614 days to reach depression remission. 614. But under the collaborative care model, it took just 86 days. That is over 7 times faster healing simply because the mind and body are finally being treated as the connected, singular system they actually are.
When you tie all this evidence together, the system-wide benefits are just undeniable. We're talking a 9% drop in psychiatric hospital admissions. 72% of primary care providers say this model is highly helpful for managing their most complex patients. It literally stops issues from escalating into acute crises. And this isn't some experimental stuff. It is backed by over 80 randomized controlled trials. Think back to the pediatric trauma and the adult metabolic issues we talked about earlier. Integrated care is exactly how we prevent those extreme scenarios from ever developing in the first place.
Which leaves us with one final, really vital question. Whether you're a patient navigating the system yourself or a healthcare provider helping to design it, are you treating the whole person or just half? Because as we've explored today, true healing only happens when the mind and the body are treated together. Thanks so much for joining me for this explainer. I really hope it gave you a powerful new perspective on the future of healthcare.